Dear friends and colleagues, it's a great pleasure for me to be speaking to you today at this symposium, the Merck Symposium. I was asked to give a lecture on how to define severe LH and FSH deficiency. Now, these are my declaration of interest. And I just first of all need to say that the indication for the use of LH is for stimulation of follicular development in adult women with severe LH and FSH deficiency. Now, this is the definition. But the problem is, do we actually have a cutoff level for severe LH and FSH deficiency? No, we don't. There's no consensus on a specific cutoff level in international guidelines. The term is just low LH, low FSH. And LH and FSH cutoffs obviously don't define the quality of the molecule, the quality of LH, the quality of FSH, nor the quality of their corresponding receptors. So again, how can we define it? Well, it's failure of generic secretion or action and any disruption of gonadotrophin action. What I'd like to discuss today is that we have to divide deficiency into congenital deficiency, and congenital deficiency is like the patient with hypo and patients with polymorphisms of either the LH and FSH molecule or the LH and FSH receptor. And then we compare those to the acquired deficiency, and the acquired deficiency is what we see after manipulation with analogs. That's the long agonist or the antagonist protocol, and then more rarely in eating disorders, diabetes mellitus and hypothalamic amenorrhea. But congenital deficiency and acquired deficiency. Now, previously, and in our daily life, we usually say, well, the cutoff of LH supplementation should be around 1.2 IU. But please remember that in normal women, LH levels will vary during the day and during the menstrual period. And again, we know that there is no consensus on a cutoff level for the definition of severe FSH and LH level. And patients can also have apparently normal LH levels, but the quality of the circulating LH is low. So this will still give them like a pattern of LH deficiency. So in reality, the only thing that we as clinicians can use to decide whether we need to add LH or not is the dynamics of follicular growth, because they're going to reveal the need or not, the dynamics of the growth and the estradiol level, obviously also. Again, just to show you that obviously during the natural cycle, we have quite high LH levels. They will vary between 6 and 8 during early follicular phase, whereas obviously during the same time span, FSH levels are significantly higher. But again, it shows you very nicely that FSH and LH work in synergy for follicular growth and steroidogenesis. And again, just to show you here, we all know the 2-cell-2 gonadotrophin concept, in which the LH, which attaches to the LH receptor on the theca cell, will activate the conversion of cholesterol into androgens, and these androgens will surpass the basal membrane, go into granulosa cell, and under the action of FSH receptor, but also the LH receptor activation, you will have a conversion of androgens into estrogens. So what I think is important here is that when we add LH from day one of the cycle, what we increase is the androgen, and androgens obviously are of benefit because they will increase the number of receptors on granulosa cells. Now, if we add LH from the mid-follicular phase, what we boost here is the growth of the follicle, as you see here, but it's also estrogen synthesis. Now, years ago, we were looking into when do granulosa cells actually acquire LH receptors, how early? And previously, it had been considered that the FSH, the LH receptor would appear on granulosa cells at a quite large follicle size, around 12 millimeters. But here in this study, we were actually able to detect LH receptor expression in at a much earlier stage, around 6 millimeters. And you can see even the 9 millimeter follicles, obviously we also had a nice LH receptor expression. Then the expression was significantly higher in the pre-ovulatory follicle. But the message from this study was that LH receptors are present on granulosa cells in at a very early stage of the follicle size. Now, we know that all our patients are heterogeneous. We have patients with acquired LH-FSH deficiency, we have the advanced age patients, and we have patients around us with low ovarian reserve. If we look into the acquired deficiency, I just want to show you here a comparison between LH levels in the natural cycle and those of the antagonist protocol compared with those of the long agonist protocol. I think it's quite obvious that with our analogs, we are working in a very low LH surrounding as compared to natural cycle. But still, this works excellently well in the vast majority of our patients because we just need less than 1% of LH receptors active to have a full steroidogenic activity. So this means that the vast majority of our patients do very well, despite the fact that we are working in these very low LH surroundings. But again, if we look into the hyper patient, we obviously know that this patient needs LH, and here a comparison between, sorry, this is not hyper. These are patients who, retrospective analysis of patients comparing baseline LH levels to stimulation day 1 levels. And what these authors wanted to show was whether which kind of LH activity and whether LH activity benefits patients who had LH levels that were suppressed by more than 50% if you compared the baseline to stimulation day 1. And they then also stratified patients according to whether these patients had a urinary LH activity, whether they had a recombinant LH activity, or they had a recombinant FSH only. And for these patients, not a lot of them, but still, it was quite obvious that if we compared urinary to the real stuff, because urinary obviously is HCG, but here we have the recombinant LH, the cumulative live birth rate was significantly higher in those patients who were treated with the recombinant LH. That is, patients who were severely suppressed in endogenous LH levels compared to baseline. Now, what about the congenital deficiency? Well, what I want to go into here today is the presence of variant LH beta, because Carlo Alivici and I did quite a lot of research in this. Now, the variant LH beta is classified by a gonadotropin which is easily measured in serum, but with a low bioactivity. So what you see is actually not what you get. And again, you see these two kids playing. You need FSH and LH. They will work in synergy. If you have less of one, you either need to add a lot more of the other one, but rather, even better, you should add the one which has a low bioactivity. And we looked into, retrospectively, into the responses of patients, of IVF patients. So these patients, we were looking into, after the stimulation, we were looking into the presence or not of the variant LH beta. And you can see that the wild type, that's a patient with no variant LH beta around, consumed very little FSH. Here you have the patients who were heterozygotes for the variant LH beta. They consumed somewhat more FSH, but the homozygotes consumed significantly more FSH. Because remember, these patients were not screened prior to stimulation, so we didn't know that they had the variant LH beta. And what we just saw was that the stimulation took significantly longer, and we needed to add significantly more FSH. And again, you see the carriers of this variant, this polymorphism, it's around 12% of our patients all over the world. Now, another congenital polymorphism obviously is the hyper patient. And again, here a small study. These are patients who underwent ovulation induction. You can see a low number, 17 and 18. But again, we don't see a lot of hyper patients. The question asked here, which is better again, to add the real stuff, the LH, or the HCG as a surrogate for LH? And again, if we look into pregnancy rate, and if we look into the total number of cycles the LH compound comes out significantly better. Here you see the cumulative live birth rate. Here you see the number of cycles. So fewer cycles used with the LH compound as compared to the HCG compound in those hyper patients until they achieve a pregnancy. In the Poseidon, we suggested a new marker of efficacy, the so-called FOI, follicle to oocyte index. And a normal FOI should end up with more than 50% of the antral follicle pool as retrieved oocytes, as you can see in the upper panel. And here is a good reserve patient, a poor reserve patient, but she still gives us more than 50% of her antral follicle pool. In contrast, here you have patients with a low FOI, less than 50% or equal to 50%, a good reserve patient, and she ends up with few oocytes. Here, a poor reserve patients who gave us less than 50%. Obviously, we want to squeeze this ovary to get at least one more egg, and here we also want to squeeze this ovary because this is usually like a good reserve patient. It could be a young PCOS patient. We didn't get it right. And this is the reason why we ended up with fewer oocytes. We didn't get it right in terms of the gonadotropin dosage and the type of gonadotropin we used. And here are the reasons for low FOI as seen by us. Usually the problem was the low gonadotropin starting dose, but also specifically in the aging patient, we have problems with asynchronous follicular development, specifically when we use the antagonist. So these patients need synchronization, and we can use obviously either the long agonist, but even more simpler, we can use estrogen 4 milligrams daily for 5 days prior to the onset of menses to get those follicles synchronized. We also have another reason for low FOI, again, is the FSH receptor polymorphism. This is 25% of our patients, they need more FSH, and its presence of variant LH beta, 12% of patients, they need LH supplementation. And then finally, another reason for ending up with fewer number of eggs could be the individual response of our patient to the HCG or the agonist trigger. When we talk about circulating serum LH levels, we have to take into account, again, the antagonist, the agonist, the type, the dose, the duration of the mode. And when we use LH, we have to talk about whether we use the recombinant LH or the surrogate in terms of HCG. And if we use recombinant LH, the dose, the day we started, day 1, day 5, day 7, and the duration of stimulation. And finally, also the LH measurement used, the LH assay used, and the circadian variation. And this is the problem with LH. We have like variation pulses still with the use of the antagonist. So it's not meaningful to measure LH during stimulation. The only thing which tells you whether this folliculogenesis or not folliculogenesis, but that follicles grow as they should is by ultrasound measuring the follicular growth. And if you do blood sampling, seeing an increase in estradiol. Now, if we specifically go into the antagonist protocol, I want to take you back to the initial dose-finding study of one of our antagonists. And here, these authors were using 6 different doses, daily doses of the antagonist, ranging from 0.0625 all the way to 2 milligrams per day. And I want to concentrate on the 0.25 milligram dose, which obviously is the dose we use today. Now, here is the morning level of LH. You can see it's around 1.8 just prior to administration of the antagonist. Now, 8 hours later, if you take another measurement, you can see now that the LH is around 0.6. So a huge variation in LH measurements during antagonist treatment. So again, it doesn't make sense to measure LH during your stimulation. You just have to follow the dynamics of follicular growth. From that study, and the reason why we use 0.25, we also see, obviously, that the lower the dose of the antagonist, the higher the LH, and vice versa. Here you have the 2 milligram and an extremely low basal LH. And there was, again, we also see a distinct correlation between LH and implantation rates. So with very low, that's high, very high antagonist, very low LH, you get very low implantation rates. And the higher the LH and the day of the trigger, the better the implantation rate. And obviously here we see the best, which is the 0.25 milligram dose. And here we also see the ongoing pregnancy rate, which came out better with the 0.25 milligram. And this is the reason why we use the 0.25 milligram, that LH is suppressed to around 1.7 on the day of the trigger, which gives us optimal results. Now, over the years, a lot of studies were focusing on the question whether a low LH levels negatively impact reproductive outcomes. And the conclusion is that a low serum LH on the day of the trigger reduces implantation, increases early pregnancy loss, and reduces the live birth rate. Now, how many eggs do we need? How many oocytes do we need? Well, again, from Humaidan, we made this statistical calculation, which was correlated to age. You here see the young patient, the aging patient, and the very aged patient. And this is from our ART calculator. So in the young patient, if you have a good lab, you would usually generally do quite well with approximately 6 eggs, because this will result in 1 euploid blastocyst. However, the older the patient gets, the more eggs you need. Here, for a 39 to 40-year-old lady, you would need 10 eggs, 10 oocytes to have 1 euploid blastocyst. And for the very aged patient, you would need 16 oocytes to have 1 euploid blastocyst. And again, remember, of the euploid blastocyst, only approximately 50 to 60% implant. So in reality, this means that to secure this patient an implanting blastocyst, you would need 32 oocytes. And obviously, we all know that this is not possible, but we need to counsel our patients and discuss the realities of biology before we embark on IVF treatment with them. If we look into the number of oocytes, we also know that the number predicts the live birth rate. This is from the Sunkara paper. And we saw from this paper that the number of oocytes to maximize the live birth rate was 15. Now, in those days, we were saying, well, this is what we want to avoid. That is the hyper responses. But in reality, today, where we have the agonist trigger in our hands, I don't see this as a problem. Obviously, I don't want to get up to 40 oocytes, but in the old days, this was a life-threatening condition. It's definitely not life-threatening any longer. What I want to avoid in those patients with a good ovarian reserve, in whom I could have squeezed this over a little more, is the low response. Now, taking you back to a more recent study of 15,000 cycles looking into live birth rate and cumulative live birth rate. In the light blue, you see the live birth rate per transfer, and you can see this study agrees with the Sunkara that the maximum is around 15 oocytes. This is where you get your maximal live birth rate, and then the live birth rate drops. And this is because a lot of these cycles will be converted into freeze-all cycles because of the risk of OHSS. And in white, you see that here is the freeze-all cycles. So obviously above 15, you will have more and more cycles, which is very wise to convert into a freeze-all cycle to avoid any OHSS. And in dark blue, you see the cumulative live birth rate. And again, we see that the more eggs you have, all the way up to more than 35 eggs, the higher the live birth rate. So again, showing you that stimulation has no negative effect. Okay, there's a high risk of OHSS, but obviously we need to use the agonist trigger. And my cutoff for freeze-all is around 18 follicles, mature follicles, that is above 11 millimeters on the day of the trigger. If above this, I would go for freeze-all. And 18 follicles corresponds quite nicely to 14 to 15 oocytes retrieved. Now, which isoform? Well, obviously it depends on the type of a patient. If you have a patient with a low ovarian reserve, obviously we would use a high potency FSH, which is the recombinant. It's more basic. More basic makes a shorter half-life, and with a shorter half-life, you have a higher biopotency. With the urinary compounds, again, they are more acidic, giving them a longer half-life. They suppress the receptor, so allow lower biopotency. And we know this from our meta-analysis also, that if we compare the efficacy of the recombinant versus the urinary, we usually end up with approximately 1.8 or nearly 2 or more eggs with the same dose in the recombinant as compared to the urinary preparations. So what about age? Well, I usually say that by age, you have an inbuilt timer in your oocyte quality. And the timer is affected by the mitochondrial function, which you can see here is definitely impacted by age, young, older, and the mitochondrial activity. Now, why do we need the mitochondria there? Well, we need them for fertilization, cleavage, and for blastulation. Years ago, some of our colleagues tried to implant mitochondria or transfer mitochondria into aging oocytes, but unfortunately, this was not feasible. So I think we have to say those studies failed. We also know that by age, around 35 years of age, again, we see a significantly higher granulosa cell apoptosis. Now, can we do anything about this? Well, what we know is that LH has a significant reduction in granulosa cell apoptosis. So this is actually where we can have benefit from LH supplementation. Another thing which affects the oocyte quality is oxidative stress, and it's general in the body. The older the body, the higher the oxidative stress. Some authors, 2 papers until now, tried using Q10 as an antioxidant for a long period of time prior to stimulation, and they were suggesting that this could increase the oocyte quality. I think we need more studies to support this theory. But the general pattern here is 3 factors which have an impact, which are actually the timers of oocyte quality: the mitochondria, granulosa cell apoptosis, and oxidative stress. Now, with age, we also know that the circulating antigens will decrease significantly. Here you see from the age of approximately 25 to at least 45, a more than 55% reduction in total testosterone. At the same time, SHBG is constant telling you that it's the testosterone output from the ovary which is reduced. And folliculogenesis is all about androgens, because androgens will induce FSH receptors on granulosa cells. The more androgens, the better the response. We see this in our PCOS patients. Androgens also act in synergy with IGF-1 for the growth of the follicle. And finally, if we have the possibility to incubate those ovaries in a low responder patient with a lot of androgens, obviously we would increase the number of preantral and antral follicles, because this has been seen in vitro and in research animals. But we actually see the same in patients who opt for transition, who transgender patients. To the left, a normal or more or less normal ovary, and to the right, an ovary which has been affected by 6 months of testosterone in a transgender person. Just telling you how important androgens are for the number of preantral and antral follicles. And obviously over the years, quite a few studies tried using exogenous testosterone, either transdermal or DHEA or whatever. But I think until now we have to say they didn't fail. And specifically with transdermal testosterone, obviously we cannot treat our patients with doses of testosterone similar to those in a transgender person. So the doses are very limited. And where we get the testosterone is more or less in circulation. Where we want it is in the ovary. Now, recently, we tried what we called intra-ovarian priming in a paper with Professor Wong from Vietnam, in which we were using aromatase inhibitors and daily HCG boluses for 8 weeks prior to stimulation to increase the intra-ovarian testosterone, which actually makes sense. Unfortunately, I think that protocol, the protocol which is in RBMO, described in an article, needs more refinement before we can say that this works. So definitely, I think we could go there, but we need more evidence, and we need the protocol to be refined. Now, when we talk about H and LH, what we also know is that the receptors present on theca and granulosa cells are less functional, and the molecule per se is less biologically active. And then, as I showed you, we have low levels of circulating androgens. So obviously, it's quite obvious that you could say that LH would be able to fill in some of the gap in terms of activating those less functional LH receptors, adding some more biologically active endogenous LH, and in boosting the circulating antigen levels. Now, we discussed the differences between HCG and LH. HCG, which we always use as a surrogate for LH activity, but obviously there are significant differences. So LH has got a lower half-life. So this results in no accumulation in serum. But there are also, LH and HCG also use different pathways. And through these pathways, they will have different impacts. So as I told you, LH has an anti-apoptotic effect. In contrast, HCG by its specific pathway has a pro-apoptotic impact. So just to conclude, LH supplementation benefits patients with congenital LH and FSH deficiency, such as genetic polymorphisms and obviously the hypo-hypo patient. Patients with acquired LH and FSH deficiency, so those patients in which the dynamic growth of the follicle is not as you expected, in which the FOI was low. And finally, also patients of advanced maternal age, for me, is an additional group of patients who face LH deficiency during ART, because we suppress the circulating LH, which is already at a lower quality, and the LH receptors are also less functional. Antigens are going down in the aging patients. So definitely for me, and this has been proven also in a number of trials, that in using LH in the advanced age lady above 35 years of age increases implantation rates. So yes, quantity matters, but quality definitely matters, and LH matters. Thank you very much.